This?
Oh, no, it's not. It's not plugged in. Yeah.
All right, so I just have to be right here. Okay. So the goals of this talk is to actually, differentiate the kinds of pain: acute, chronic, neuropathic, somatic, and visceral pain syndromes, and discuss different kinds of pain analgesias that we can use in the inpatient ward, such as, over-the-counter medications, SSRIs, SNRIs, anticonvulsants, and limitations in use of opioids. And I'm also going to briefly discuss some of the factors that affect dosing and drug half-life on renal function and hepatic function in opioids, as well as the Ohio guidelines when you're prescribing opioids at discharge. So let's start with talking about the types of pain. You can basically differentiate pain based on the duration. You can say whether it's acute or chronic pain. Acute pain is basically, it starts out sharp or intense before it gradually improves. It's usually less than 30 days as far as the duration of the pain, and it should get better during the time course. Some examples: post-surgical pain, overuse injury, trauma. Chronic pain are pains that last for more than 6 months, even though the initial injury has already been healed. It can be caused by past injuries, but sometimes there's no clear cause. Some examples: frequent headaches, nerve damage pain, low back pain, osteoarthritis, fibromyalgia pain. Then you can also look at this defining pain based on their source. So nociceptive pain is caused by activation of the nociceptors in the body by painful stimuli or potential harmful stimuli. You can divide it by either it's a somatic or visceral pain. Somatic pain, it originates from the receptors in the surface of the body of the musculoskeletal tissue. It's easier to localize, and it's worse productivity and relieves by rest. Visceral pain, it's pain from the receptors located in internal organs. It's described mostly as deep, pressure-like, squeezing, cramping. Oops. Okay. And then there's also neuropathic pain. This is because of nerve injuries that's involved in the propagation of the electrical signals that sends messages of the pain from the receptors to the brain. So a lot of patients will describe this: I have shooting pain. It's really intense. It's numb. It's tingling. I feel like electric shocks going down my leg. Typical examples: postherpetic neuralgia, diabetic neuropathy, HIV neuropathy, phantom limb syndrome. Then you can also talk about psychogenic pain. These are pains that are associated with some psychological disturbances like anxiety, depression, stress. It can be a consequence of stress or have an effect on the pain. So let's kind of talk a little bit about a simple case. This is Mr. Jones, comes into 65-year-old with past medical history of hypertension, hyperlipidemia. He presented in the ER with complaint of right-sided chest pain for 2 days. The pain is same with exertion and at rest. It's not associated with food. He denied any recent trauma. His initial workup revealed that his BNP, CBC, troponin, EKG, and chest x-ray were all normal. So based on the duration, what kind of pain is this? You guys can just shout it out. It's acute. He describes the pain as sharp, burning, and tingling sensation, and then he lifts up his shirt and he shows you this. So what kind of pain is this based on the source? Yeah, it's zoster. So what is that kind of pain? Right, it's a neuropathic pain. So let's go over the medications we can use. Typical NSAIDs is the most easiest one we can do. Everybody has, NSAIDs over the counter. It's very effective in combination with muscle relaxants, especially for low back pain. It's good at reducing swelling and pain caused by muscle strain or sprain. You have to be very careful. A lot of patients we take care of in the wards, they have CAD, CVA, renal disease, peptic ulcer disease, GERD, or bleeding disorders, which most likely they're already on some antiplatelet. So that's one of the something that you have to be watching out for, because multiple antiplatelet will increase the bleeding of your patient. One medication that can bypass this is COX-2 inhibitors agents, Celecoxib or Celebrex. It doesn't affect the platelet function, or directly increase the bleeding risk. So that could be another agent that you can use if somebody's already on a lot of antiplatelets. Tylenol or acetaminophen, it's very effective in treating acute pain, especially when you schedule the dosing. You just have to be very cautious in patients that have heavy alcohol use or already have advanced liver disease because it is cleared by the liver. Maximum dose is 4 grams per day. You can also use topical agents, menthol, methyl salicylate. They're counter irritants. What they do is they basically exhaust that nerve signal and basically nulls it out. It's very useful in managing musculoskeletal injuries, but the skin has to be intact when you put it on. And the only thing is it has to be applied for multiple times a day. Some of them can have not very good smell, so the patients don't like it. But it tends to be very effective. You can also use lidocaine patch or gel. So let's go with another case. This is Mr. Smith, who's 45-year-old obese male with past medical history of hyperlipidemia. He's on Lipitor. He presented in the ER with complaint of low back pain. He was helping his daughter move to a new house 3 days prior to presentation and was lifting a heavy box when he felt a sudden sharp pain along his lower back. He's able to walk, but with significant pain, worse when moving. Your neuro exam is unremarkable. Labs and imaging, it was fine. You diagnosed him with low back muscle sprain. What's the best medication for him? So yeah, ibuprofen and Flexeril, they tend to really work well. It decreases that muscle spasm and the inflammation with ibuprofen. Now, anticonvulsants, they're our first-line treatment for neuropathic pain. When you're dosing it, always start low and go slow when you're titrating them. Some patients that are resistant, it's sometimes useful to use 2 combinations and use ones that have different actions of mechanism. Increase the dosage until you feel like the clinical effectiveness is seen or you're starting to have adverse effects. There's a black box warning, though. It increases risk of suicide. So some of the anticonvulsants, we use gabapentin or Neurontin. This is the first-line treatment for postherpetic neuralgia. It's also effective in diabetic polyneuropathy. It's fairly well tolerated in a geriatric population, but it is renally excreted, so you have to make sure your dosing is correctly, especially when you're a CKD patient, so you might have to back off on the dosaging. It can cause somnolence and dizziness. Lyrica, which is kind of a derivative of gabapentin, this is pregabalin. It's FDA approved for neuropathic pain that's associated with diabetic neuropathy, postherpetic neuralgia, and fibromyalgia. Same as gabapentin, it can cause some dizziness and somnolence. Another side effects, though, is peripheral edema and dry mouth. So if patients just keep complaining, they keep having these swellings, do review their medication list. They might be on some Lyrica. Carbamazepine or Tegretol, it's commonly used for trigeminal neuralgia. It's a little bit harder to use this because it has very erratic absorption. It does cause sedation, nausea, vomiting, liver enzyme induction, and it definitely requires that you have to closely monitor it because it can cause leukopenia, thrombocytopenia. It can get patients in aplastic anemia, and it does prolong your QT. I don't really use this very often. Topiramate or Topamax. This is very good for migraine headaches. It reduces about 50% of the attack, but this does cause some birth defects. So if you're using it on childbearing women, make sure that you check a pregnancy test. It also causes some weight gain. It can cause some hepatic injury and thrombocytopenia, so you might want to get some baseline labs as well. Valproic acid is also good for migraine headache, and it was approved by the FDA for use of migraine headache in 2004. Although it has some variable effectiveness when you're using it with diabetic neuropathy, but it can cause some weight loss and cognitive dysfunction. It might be a little bit difficult to use this on your older patients, especially when they're already not eating very much and they're having dementia. So antidepressants, serotonin and norepinephrine reuptake inhibitors are also useful for neuropathic pain. SNRIs, though, are CYP450 enzymes system and can cause delayed clearance of a lot of the medications we use on the wards, cardizem, fluoxetine, Flagyl. So just be very cognizant of that. It also does increase the risk of suicide as well. So Cymbalta or duloxetine, it's good for diabetic polyneuropathy, fibromyalgia. It also treats major depressive disorders, but don't combine it with MAOIs because it increases your risk of serotonin syndrome. And same thing with CY450 inhibitors, just because the clearance. Venlafaxine or Effexor, it does have good response for neuropathic pain. It does increase your risk of serotonin syndrome as well when you use it with TCAAs, SSRIs, tramadol, buspirone, MAOIs. So kind of have to be vigilant of looking for the right patient for that. So let's look at the next case. Mrs. Jones is a 60-year-old female with past medical history of depression, hypertension, uncontrolled diabetes with an A1C of 11. She's also non-compliant with her medication. She was admitted for chest pain and ACS was ruled out. During rounds, she complained of shooting, tingling pain along her feet. She states that sometimes she can't sleep because her feet feel like they are on fire. She has also been feeling down since she stopped taking her antidepressant 6 months ago. What would be the best medication to help her? Yeah. So duloxetine would be getting 2 birds with 1 stone. You're treating her diabetic neuropathy along with her depression. Good. So this is just a busy table, but it just summarizes a lot of what we just went over really quickly. Gabapentin for postherpetic neuralgia, Lyrica for diabetic peripheral neuropathy, postherpetic neuralgia, fibromyalgia, Tegretol or carbamazepine for trigeminal neuralgia, Topiramate for migraine prophylaxis, same with valproic acid for migraine prophylaxis, Cymbalta, diabetic peripheral neuropathy and fibromyalgia, and venlafaxine for neuropathic pain. So let's talk a little bit more about opioids. So since this whole opioid crisis, there's a lot more of concern as far as making sure that prescribers are very, very vigilant as far as they're picking the right people to give opioids. When you are thinking about prescribing opioids, make sure that you're checking their opioid use and their history. You want to evaluate the risk of addiction because you don't want them to be hooked on these medications. And you want to make sure that you're evaluating their risk of excessive sedation and respiratory depression, especially on those that have already pulmonary disease, your COPDers, your chronic CO2 retainers. You don't want to depress their respiratory drive even more and then cause more problems with the opioids. So when you're looking at the history, check if there's any allergies or any adverse drug reactions when they've taken opioids before. You want to check for any prior use. With our system, it's already linked to the Ohio Automated RX reporting system. You just click on it. Once it'll pop up an entire summary of what narcotics or what controlled substances a patient already has and who's been prescribing them. So you can kind of tell whether they're doctor shopping just to get a lot of their opioids. You want to evaluate the risk of addiction. So a Cochrane review in 2010 basically looked at long-term opioid therapy is associated with lower risk for addiction when it's given to selected correct patients with chronic non-cancer pain, no history of substance addiction or abuse. But if they're not properly used and properly not screened, some patients, 10%, who were prescribed opioids within 7 days after low pain surgery, were still using them a year later. 6% of those patients who had post-operative opioid prescription for more than 150 days after surgery, and about a quarter of the patients having total NIP, total hip, or total knee arthroplasty were still taking it for 2 years later. You can use an opioid risk tool. You can it's Medscape it or MedCalc it, just Google it. It looks at their actual risk of how they can get addicted. Patients with family history of substance abuse or personal history of substance abuse, pre-adolescent sexual abuse or psychological diseases. Patients, they've been finding a lot of people that has underlying psychological diseases tend to have a higher risk for being, for addiction. So it's graded based on your risk. Greater than 8 is very high, less than 3 is low. 47 is moderate, so you want to risk stratify them even more. Side effects of the opioids, constipation, itchiness, nausea, dizziness, sedation, muscle jerks, or rigidity. They're not the same as allergies, which are basically anaphylactic reactions or hives. If someone does have a true allergy, though, you want to stop it right away and consider replacing it with a different opiate from a different analog class. Side effects of constipation, pruritus, and nausea, you should always anticipate them and prepare for them and manage them. So anybody that's being prescribed opiates, you want to put them on a bowel regimen, put them on Atarax to kind of help with the pruritus. Or patient may also need a different opioid if side effects are not tolerated. There's multiple ways you can administer it. You can do it by IV, sub-Q, PO, PEG tube, transdermal, which is mostly your fentanyl, transmucosal, sublingual, or rectal. Oral is always the preferred route when the patient is able to swallow. Sublingual and buccal formations are available for those who can't swallow pills. Do not use it IM because it's painful. You can give it sub-Q or IV. They're usually equivalent in terms of onset and duration, though sub-Q is more uncomfortable and has a less consistent pharmacokinetics. You guys probably have seen this before. This is just morphine equivalence table. It basically looks at the relative strength, and you can calculate the dosage of how much your patient can take or the equivalents that they've been taking on their pain medication. Obviously, fentanyl and methadone are the highest strength that you can give them. We don't necessarily use them in the wards acutely. A lot of these are used in chronic pain patients, especially cancer patients. Tramadol is also another one that is not on this list. It's about 1/10 of the strength of morphine, but it is still an opioid. So when you're thinking about dosing on adult patients with mild pain, less than 60 kilos, or elderly patients, start with about 2 to 5 milligrams of morphine, immediate release about every 4 hours. Greater than 60 kilos with moderate to severe pain, 5 to 10 milligrams of morphine equivalent every 4 hours. So looking at renal function, it shouldn't preclude you from giving it to any patients that have renal insufficiency. The best ones you want to use is fentanyl and methadone, although we don't really use this because this is the highest, most potent opioid that you want, but they are very easily renally cleared and it doesn't really cause a lot of problems. Methadone is a little bit more harder to manage, and it's usually prescribed by palliative or pain management doctors. So we tend to rely more on the second box, oxycodone and hydromorphone. Oxycodone, you can use it in renal insufficiency, just use a lower dose, and you want to increase your interval, and you want to look at their tolerance. Dilaudid or hydromorphone, the active metabolites accumulates quickly, especially if they're on dialysis, but it is removed by dialysis. So you want to carefully monitor them, but it can be safely used when patients are on dialysis. You want to use it cautiously, though, on patients with less than 30 ml of GFR, especially if they haven't used dialysis, because it does, like I said, the metabolites accumulates, and you can cause respiratory depression. And do not use long-acting or extended-release morphine on patients with renal insufficiency. The metabolites, which is morphine 6B glucuronide, actually stays in the system, and it's actually penetrable through the blood-brain barrier, so you can cause CNS depression on patients with renal insufficiency. Same thing with meperidine, can cause seizures on patients, and codeine can also cause profound toxicity. Patients with liver failure, obviously the liver failure will cause decreased clearance of the opioid and increases the drug bioavailability. So you want to start at lower dose of most opioids on those patients, especially with end-stage liver disease, which we see a lot of cirrhosis in our patients. Be very cautious in prescribing opioids at a regular dosing. Don't schedule them I wouldn't recommend scheduling them on a timely basis. I would always use them as PRN. And you want to know how the patients are tolerating it and the dosing interval as well. Those with worsening liver function should be closely monitored for signs of drug accumulation and need for dose reduction, assuming you're still achieving the level of analgesia that you want and the patient is still comfortable. Always consider drug interaction with CY450 enzyme system. So the safest, just like patients with renal failure, fentanyl is also pretty well tolerated by patients with liver failure. Morphine in early liver disease, you just want to use a lower dose, but you can still use it in the normal dosing But when you start having a lot more advanced liver disease, patients with already cirrhosis, you want to do a longer dosing interval. With oxycodone, you want to start about 30 to 50% of the recommended starting dose. Hydrocodone or Vicodin, the dose titration is limited because it's already attached with Tylenol, and you already want to make sure that you're not giving too much Tylenol on a patient that already has liver function problems. So you want to start about 50% of the normal dosage, and as the disease progresses, you want to increase your intervals when you're administering them. Methadone, it's actually easily cleared with patients who have infections with hepatitis C virus, especially in the early course. It's also, like I said before, it's hard to titrate and initiate, so we leave it more for palliative or pain management. Codeine and meperidine, you don't want to give it to those patients that have liver failure because it does have toxic metabolites that accumulate. Same thing with Dilaudid. The glucurinated metabolites basically doesn't have any analgesic effect, but it becomes neurotoxic on patients that are not able to clear it up. So, case 4. Mr. Joe is a 60-year-old male with past medical history of compensated alcohol cirrhosis, hypertension, and hyperlipidemia, who was admitted for right ankle pain after a mechanical fall and found to have a distal tibia fracture. He was taken to the OR for an ORIF without any complications. What pain medication should be avoided for this patient? Yeah, Dilaudid, hydromorphone, because you don't want that toxic metabolite accumulating in him. So, just to recap, things to remember when you're prescribing opioids: order a bowel regimen to prevent opioid-induced constipation. In patients receiving opioid stimulants that are recommended, Senna, Bisacodyl. I won't recommend Colace. It doesn't really do very much. So you want a lot more peristaltic effect when you're giving opioids. Limit co-administrations with other opioids or other CNS depressant medications, benzos, muscle relaxants, some SSR antidepressant can cause depression. Look at their response. If they're improving and their pain is getting better, you want to start pulling back on your opioid dosage and also the intervals. Ask about, when you're getting ready to prescribe them from home, ask about previous opioids at home and account for those that they already have, so you're prescribing the minimal amount that they'll need when they're at home. And then as far as rules for prescribing in Ohio controlled substance rules is very extensive, since I don't even know it's going to pop up. It's very, 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 very long. But basically, it covers anything that physicians should be doing. And if you are not compliant with it, then you can face some repercussions from the medical board. So you want to be aware of that. I do want to just look at the general provisions that you basically, what they want you is to utilize opioids properly. You're looking at the risks of these patients for addiction. They obviously don't want you selling opioids or giving this to patients who are high risk. It's basically this general provision that they want. They also want you reviewing the ORS, especially in the patients that you're prescribing it for greater than 7 days. So always review your ORS whenever you think about prescribing to any patients, especially when you're doing it as an outpatient, when patients are just wanting it to be continued because of their chronic pain. There are instances where you don't have to review ORS. So hospice patients that have terminal diagnosis, you don't have to do it. Prescribing in-house in the hospital, in a residential facility or nursing home. If you're prescribing it for less than 7 days, or if you're prescribing for treatment of cancer or other cancer-associated pain, treatment for acute pain that's from invasive procedures or delivery or surgical procedures, you don't necessarily have to, but I would still, just out of practice, just always get your ORS. You want to document that you review their risks. There's a dot phrase that we have on Epic. It's just .ORS, and it'll just tell you that if you reviewed it, if there's any concern about this patient and why you're prescribing certain amounts, or why you're not prescribing opioids for that patient. Okay, questions?